do it now on this way. Can you now see the presentation?
Yes, Stefan, we can see the presentation, just not the completely mode to present.
Okay. You see it now?
Yes, all your slides, but right now, yes. Right now,
okay, sorry, perfect.
Thank you.
So, could I start?
Yes, please, Stefan, just that we can see you. Maybe you have to open your video, your camera.
How do I get there? Can you see me now?
Yes, exactly. Now we can see you. Thank you so much, Stefan.
Sorry about that. So thank you very much for your great invitation. Today I will present some data about Darunavir, cobicistat or Ritonavir. Here are my disclosures. So I want to start with some trials to antiviral naive patients, then to switch, then to NRTI sparing regimen, then to treatment experience, then to cohorts, then to meta-analysis, and then perhaps to our own experience with this drug. And please, if you have any questions, please stop me. And you know, Darunavir is a very old drug, so we have a lot of data about this. And here are some of the data over the time I want to present and discuss with you. And let me start with the first trials for antiviral naive patients. You see here, these are the German guidelines for, or the recommendations for antiviral treatment in the first line. And in the German guidelines, Darunavir combined with cobicistat and TAF and FTC is still recommended as one option in the first-line therapy of people living with HIV. In the DHS guidelines, you see there's only there are only regimen recommended, including integrase inhibitors. But in the alternatives, there are many different Darunavir containing regimen recommended. The German guidelines don't recommend anymore. So I will show you later on why we decide not to promote these some of these options. Okay, let's start with the naive trial, a very older study, of course, but I think it was a breaking point and a very interesting study. This study is a ACTG 5257 study where boosted atazanavir was compared with boosted darunavir and raltegravir with the backbone of TDF and FTC. And they were compared with each other in the intention to treat trial. And you see here the snapshot, and there raltegravir was superior to both boosted PI at week 96, and darunavir ritonavir was superior to atazanavir ritonavir. So atazanavir ritonavir is not often used in Germany anymore, and here you see the different composite endpoints, and the tolerability failure was the reason why raltegravir was superior to darunavir. But if you see virological failure, all the regimens were equivalent, But you see that in the PI regimen, there were no major PI mutations, and there were many problems with hyperlipidemia. So this we will see later on. Now, a newer study where darunavir, ritonavir combined with two NRTIs was compared with duravirin with two NRTIs. And you see here that the results were comparable with each other, but the difference was again that there is no PI resistance found in the darunavir regimen. So also in this naive study, it seems to be a very potent drug, and the difference makes adverse events. And here you see especially the lipids, but also with diarrhea, there was a difference. And so you see more adverse events leading to a discontinuation of darunavir compared with duravirin. Now, and this is new data, the data you want to hear at the end of the day, the AMBER trial, where darunavir was combined with cobicistat. But in Germany, we have only a single tablet regimen combining cobicistat, darunavir with emtricitabine and tenofovir alafenamide. And here in this trial, the AMBER trial, this combination pill was compared with TDF, FTC, and darunavir in TDF and TAF. This was the difference at the end. And there you can see the modern trials are not comparable with the older ones because the patients have a higher CD4 count. Not many patients has really a high viral load. So in the new trials for treatment naive patients, we start much earlier than in the older trials. So it's difficult to compare the results of the older trials with new trials. But at the end of the day, you see that the classical therapy of darunavir, cobicistat, tenofovir alafenamide compared with TDF was as effective. And also over a long run, we see a very good efficacy, more than 90% reach the level below the level, viral load below the level of detection at the week 48. And still after 96 weeks, we have very good efficacy over the time. And here also in the longer run of the study. Again, in this trial, in both arms, there were no darunavir resistance observed over the whole time. So still in the first line therapy, no resistance develops against this PI. But of course, here you have the same adverse events we have already seen in all the other trials, diarrhea, rash, nausea, but the discontinuation rate in this trial is much lower. So perhaps a combination from TAF, FTC, darunavir, and cobicistat is better tolerated than a TDF, FTC, darunavir, ritonavir combination. So these data seems to be better than the older results in the studies, but you can't compare the different study groups or study populations in older trials and the new trials. And there is still an increase in the fasting LDL cholesterol as one of the most frequent adverse event, but the number is not so high. The other thing is that the diarrhea or the gastrointestinal adverse events, which may be a problem in the use of darunavir, the incidence decrease over the time of diarrhea and other gastrointestinal complications of this treatment. So there's a rapidly decrease after the introduction of this treatment. Another discussion is it possible to start immediately with a treatment-naive patient at the first appointment with the antiviral therapy? And you know also from other drugs, the quick start of antivirals seem to be successful in special settings. In Germany, normally this is not necessary. The patients come back and they don't come from far away. So we don't have many needs for rapid antiviral therapy initiation. But you see here from this trial that the results also over the first 24 weeks are very good, with a high efficacy if you start immediately. So at this time, of course, you have no resistance testing, and this is part of the regular examinations in Germany before you start treatment. And but it seems to be not absolutely necessary if you want to have a rapid start of your antivirals in a special settings. Now I want to continue in a switch setting, the Emerald study also with TAF, FTC, Darunavir, and cobicistat. Here, all patients have to be below the level of detection more than 6 months before they can enter in this study. And then there is one arm when the patients continue the old regimen, the old PI, but also again with the TDF FTC backbone compared with a switch to Darunavir, cobicistat, FTC, and TAF. And at the end, you see a very good efficacy over the time. So the label for the single tablet regimen with Darunavir, cobicistat, FTC, and TAF is in the US for treatment-naive patients, for patients with virologic suppression for more than 6 months. In Europe, it's more open, and it should be taken with food. In Germany, there is no special food restriction with this combination, but there are many drug-drug interactions because of the boosting of the regimen. So what is a big discussion? I don't present you the monotherapy trials anymore. You know that the monotherapy trial was not non-inferior compared with the triple therapy. And at the end, over the time, the triple therapy was even superior. So there was the idea, perhaps we can make an NRTI sparing regimen. And one of the first studies was a combination combining Darunavir, Ritonavir with Raltegravir compared with Darunavir, Ritonavir, and TDF FTC. At this time, everybody expected that Raltegravir might be a more potent drug than TDF FTC. So many of the experts expect that this arm, Darunavir, Ritonavir, plus Raltegravir, might be more effective or potent than the classical triple regimen. And as you know, especially in people with advanced immune stages, the classical therapy with a new backbone and Darunavir, Ritonavir, or was more effective than the combination Raltegravir and boosted Darunavir. So in Germany, Christoph Spinner, Antonia, perhaps you know him very well from different meetings. We were also together when we have the honor to visit you in Mexico City and have a great time there. I remember that, and I hope we can come back to Mexico City. And Christoph Spinner makes the Dualis trial, and there the idea was perhaps a combination of boosted darunavir with dolutegravir might have better results than we have seen in a combination of raltegravir with boosted darunavir. So there were two arms. One arm continues with boosted darunavir and two NRTIs, and the other arm switched to boosted darunavir together with dolutegravir. In Germany, it's a typical trial. The most German patients, of course, are Caucasians, and 47% have a CD4 nadir below 200, and of course, HPV infection was an exclusion criteria, as in all trials where you don't use TDF as a backbone. And what you see is that both arms are comparable. 88% have a viral load below the level of detection in the classical triple arm, and 86% in the 2DR arm. And the virological failure was comparable, but in all treatment arms, there were no treatment emergent resistance mutations. What was really interesting, that there were more adverse events in the intervention arm compared with the triple arm. So we don't see so far any advantage in adverse event. And what we see again, like in other trials, also the lipids were higher in the 2DR arm compared with the 3DR arm. So you know about the discussion that TDF might lower the lipid levels when it's used in an antiviral regimen. But also in weight gain, there was seen a higher weight gain in the 2DR regimen. You know, the second generation integrase inhibitors are candidates for a higher weight gain compared with all the other drug classes and other drugs we use in antiviral treatment. And you see also weight gain was significantly seen more often in the 2DR arm when you combine boosted integrase in the integrase inhibitor with the boosted protease inhibitor. So at the end of the day, the NRTI sparing regimen and the combination of an integrase inhibitor with the boosted darunavir has no advantage in the rate of adverse events and has a higher weight gain, and dyslipidemia was more frequent. Then after this, there was a switch from all the patients who have used in the backbone of this trial TDF, and they were switched to TAF, and there were no significant difference in weight change between the groups. And perhaps the impact of TAF on the weight might be not so high as the impact of second generation integrase inhibitors. And the other thing is the lipid lowering effect of TDF gets lost. So there is an increase in the different lipids after the switch from TDF to TAF. So the Andes trial also performed, especially in South America. There, TDF, 3TC, darunavir, ritonavir was compared with the dual regimen 3TC, darunavir, ritonavir. And there you see the same effects. The efficacy seems to be the same in the dual arm, but the lipids were higher in the dual arm compared with the triple arm. So again, there was no significant difference in RAs or serious RAs, and the lipids, the increase in the lipids were even higher. So for this combination, so far, there is no advantage shown for dual therapy compared with the triple therapy. So another trial we take also part in was a simplification trial. The simplification trial for heavily pretreated HIV positive persons. And there, the patients who has in their history 2 or 3 drug resistance and had viral load below the level of detection for more than 6 months, there was a trial to simplify their regimen. So far, they use more than 5 different drugs and or tablets every day. And so the idea was to simplify this regimen to a 2-tablet regimen. So there was a combination of tenofovir, emtricitabine, cobicistat, elvitegravir plus Darunavir. And I don't present all the different data from small studies, but this simplification works very well in the patients, but you can also combine, of course, some TUTSA, so the combination TAF, FTC, cobicistat, and Darunavir is called in Germany. I don't know if the same in Mexico, the name is in Mexico the same, but this also works very well. So this perhaps is even more potent than this combination. But what can be shown that the cobicistat in elvitegravir is also potent enough to make a boosting which is high enough also for Darunavir. So there are 2 different possibilities to make a simplification therapy, including Darunavir for heavily pretreated patients. And especially these patients are very happy that they also get the chance to have regimen with less pill counts. Only I show only a historical trial because now we have actual new trials for heavily pretreated patients, for example, with fostemsavir and other new drug classes. But a couple of years ago, the combination of a new second line integrase etravirine as a non-nucleoside reverse transcriptase inhibitor plus protease inhibitor boosted was a real innovation and is showing very, very good results also in these heavily pretreated patients. So this might be an option in some patients also for the future who had where the regimen doesn't work anymore. Now, what is also very interesting are some cohort data from different trials. And one of the cohorts we know, or here is a collected data of Darunavir once daily regimens, and there they look for, again, for PI resistance. And you see in all these pooled trials with more than 3,635 patients, no development of resistance was seen, especially also not in the backbone. But a big study like the DID trial, one of the most important trials showing adverse events over the time in a big cohort. And here they analyze the cardiovascular risk of different drugs, and they also look for the cardiovascular risk for second generation protease inhibitors. And as cardiovascular disease or risk, myocardial infarction, stroke, sudden cardiac death, and invasive cardiovascular procedures were defined. And there there was no higher risk shown for atazanavir ritonavir, but the risk for boosted darunavir was higher compared to other drugs to develop a cardiovascular event. But in the study, they don't distinguish between a dosage of darunavir ritonavir 800, 100 QD versus darunavir ritonavir 600, 100, because the double dosage of ritonavir, we know already, might have an impact on the risk of cardiovascular diseases. And these data you have seen many times and you know very well. There seemed to be a difference in weight gain in treatment naive people living with HIV between the different drug regimens. And at the end, NNRTIs and PIs have a lower risk for weight gain than integrase inhibitors, especially second generation integrase inhibitors. This might be perhaps an advantage. And patients in the PI cohort, also in other cohorts, were less likely to experience weight and BMI gains than patients in the INI cohort. I think the BMI is also important because weight gain is sometimes discussed as the coming back to normal. Then when you have not treated patients, I think at the end, HIV is a consuming infection. So if you stop the HIV replication, of course, everybody might have a weight gain. But we see also weight gains in the switch setting or other settings when we use integrase inhibitors, or higher weight gains compared to the use of protease inhibitors. And here, this is a very interesting study, including 10,000 patient years, comparing the use of TDF with TAS, and is analyzing the advantages and disadvantages. Many of you perhaps might know Andrew Hill, who is a good biometrician and making very interesting analyses in the HIV field. And what was interesting when we look for today for darunavir cobicistat, what might be a difference in the use of a regimen darunavir cobicistat with FTAF compared to TDF. And at the end, the use of TAF and TDF without ritonavir or cobicistat makes no special benefit. But the use of TAF and TDF with ritonavir or cobi had significant higher rates of high-foreign RNA suppression for TAF and lower risk for renal and bone-related adverse events. Decreases in bone mineral density from baselines were smaller for TAF versus TDF. So we know all this very well. And what is very interesting, that especially the kidney damage, when we use combinations of protease inhibitors with, or darunavir with tenofovir alafamide, is much lower than we use darunavir together with tenofovir alafenamide. So coming back to the recommendations in Germany compared to the recommendation of the DIS guidelines, this is the reason why in Germany a combination of darunavir, cobicistat together with TDF is not recommended anymore. So at the end of the day, we have very, very good data about this drug. We know a lot about the drug. At the end of the day, I would like to ask you, how many skin rashes do you really see when you use darunavir? It's always in all guidelines, and also it's described in some studies. We don't see a lot of skin rashes, and but we see gastrointestinal adverse events like diarrhea You know, it's a potent CYP3A4 inhibitor, so you have many drug-drug interactions. But in one great observation, a cohort study, you see an increased cardiovascular risk, but so far not known is this is also true for once daily doses with cobicistat. The hepatotoxicity has been also reported in patients with a pre-existing liver disease. And of course, COBI inhibits the active tubular secretion. And so the co-administration with TDF is not recommended in patients with creatinine clearance below 70. And at the end of the day, it's perhaps not a good idea to combine it from the German point of view with TDF. And so far, but we don't know the impact of cobicistat, TAF, and TAF on pregnancy and on the pregnant woman and their children. So from our point of view, when you see the clinical trials over the last 10 years, the Darunavir seem to be really a very potent drug with a high resistance level. So it's still part in Germany of many regimens used in treatment experienced heavily pretreated patients with virological failure and multiple resistances. So the high barrier to resistance and the broad resistance profile of boosted Darunavir is the reason for the use in so many salvage regimens. But we still consider Darunavir also in some treatment naive patients and other, especially in patients who may have suboptimal treatment adherence, because we see it takes a long time to get a drug resistance, even in patients with suboptimal treatment adherence, to develop many resistance against protease inhibitors so that they don't work anymore. So there might be an option, Darunavir, for these difficult to treat patients. Okay, and if you plan a rapid start, of course, cobicistat Darunavir with backbone is an option. So at the end of the day, in Germany, Darunavir is still a very interesting drug, often used in special settings. And I don't show now many clinical cases with the answer at the end, okay, Darunavir is the treatment of choice. But perhaps I can show why we in Germany still recommend Darunavir and still use Darunavir in, for example, in many special settings. Thank you for your attention, and I hope this presentation was like you expect.
Thank you so much, Stefan. I think it's similar like in Germany. Here in Mexico, we don't have, for example, lopinavir or atazanavir anymore. It's just in so few patients. I think the Darunavir right now is the most common in Mexico. And the Darunavir cobicistat, like a single tablet, because here in Mexico we have Darunavir for 400 milligrams, 2 tablets, plus 1 ritonavir, 3 tablets. Then it's easier when we use Darunavir cobicistat in 1 tablet. With one more, maybe tenofovir and emtricitabine, or 3TC, or maybe dolutegravir, like in Dualis that you presented, that Christoph Spinner developed in Germany. Well, I think we have some questions. For example, what is your experience with a double therapy? Not exactly with dolutegravir, but Darunavir cobicistat plus 3TC. I don't know if you have experience or in in which cases do you use this kind of regimen, Darunavir, cobicistat plus 3TC?
We have good experience in many patients, but the reason why we do it are not adverse events. We have some patients which are who are completely resistant against TDF and abacavir, and they don't have many treatment options, so they start in a time where we don't have so many options like we have. And so we decide to combine with 3TC, because 3TC, even if you have a 184 V mutation, the replicative capacity of HIV is reduced heavily. So it's a great advantage to still use 3TC. And so if we have not too many PI mutations in some salvage, then it works amazingly well to use these combinations, 3TC with boosted Darunavir. And these patients are below the level of detection now for many years, so we don't see any reason to switch them if they don't have lipid problems or other problems. So they are happy with this therapy. And I know in some countries, perhaps not in Mexico, not in Germany, for example, in India, there is a single tablet regimen with these 3 drugs. It might be even more interesting. In Germany, now it's still 3 tablets every day. So it's not very attractive because we don't have a combination cobicistat with Darunavir. So they still use a high pill count, and this doesn't make us happy. But it might be a very good option in some patient, and from our experience and from my personal experience, it works very well.
Perfect. Thank you, Stefan. Right now, that maybe we have patients with depression, we have patients with a lot of neuropsychiatric problems, or maybe that during the integrase inhibitor treatment, they develop insomnia, that is very common, depression too, or anxiety. I think that to change for another kind of drug like maybe non-nucleoside like doravirine, or maybe like Darunavir cobicistat, like the detox trial, I think that is the name. That when they change because of neuropsychiatric problems to doravirine to Darunavir cobicistat, I think we need more options to pay for our patients that is not only integrase inhibitors. What do you do in your clinical practice when you have neuropsychiatric problems, or when you have patients that are gaining a lot of weight? What do you do? Do you think that Darunavir cobicistat is a choice in these cases?
Thank you for this question, because this is a very important point, because we have a big discussion also every week in our team, because in the studies, you don't see the same effects as in the great cohorts. You know, Christian Hoffmann shows a very nice presentation about neuropsychiatric problems when you use second generation integrase inhibitors. And the data seem that around 10% of the patients develop depressions or have a worsening of their depression or other neuropsychiatric problems. All the companies don't show that in their studies, in their data, but in the real life cohorts, you see it in many, many different cohorts in Mexico, in Europe, in different countries of Europe. There are very nice presentations and very good data about this problem. And at the end of the day, depression has also higher risk for other diseases, cardiovascular diseases, but also for a worsening of compliance. Many patients who have depression stop taking their pills regularly, and this is a great risk. So we discuss this with our patients, and there are some different patient profiles. And many of our patients using a second generation integrase inhibitor has also a history of resistance. So you again need a really potent drug in your regimen to make sure that there is no virological failure again. And for these patients, the PI is really an option. And the other problem that you then have higher lipids, then we add a statin. Sometimes it's better to use protease inhibitor with a statin than to tolerate that the patient has depressions over a long time, and then the patient lose his compliance, and then you lose a very important option. And of course, then you have a two-drug resistance. And even if they have a bad compliance, I think the PI is a better drug compared with other regimen. So at the end of the day, yes, this special population, we have switched some patients, and at the end we see, but this is not scientific data, this is our impression, that in some patients the depression or the neuropsychiatric problems decrease. So it might be an option. You have to discuss with your patients like you do, and then you have to try. Not in every patient is a success. We have also some patient with depression, for example, we switch and nothing happens. So at the end of the day, we have only the possibility. I think we have no predictive marker. Who are the patients who have the best success? We have to try and discuss with our patients. So this is for some in the patients a good option to switch in this regimen. And in the weight gain discussion, this is a difficult question because there is a group of the people who have weight gain and they have lipid problems, both. I think then it's not a good idea to switch to an PI. It's also not motivating a person. At first has only weight gain, and then he has still weight gain. So we need more data, what regimens we have that stop the weight gain. Here in the people without resistance, we prefer at the moment an NNRTI regimen. For example, a Darunavir regimen in person with weight gain, and not in neuropsychiatric, we see more with PI at the end of the day. In the weight gain group, in our special group here in Germany, you ask for my experience, we would prefer at the moment to use Darunavir. We don't see then a weight loss, but we see a stable weight. And if the persons with the weight gain start then to make sports and diet, they have a chance to lower it. But we don't see that the switch alone is a success. You have to add with other things. It's not enough to switch. And so now we have decided to offer earlier the patient a switch before he has already an increase of weight 5 or 10 kilos. So we say if the person have more than 3% weight gain in 1 year, or then we suggest, what do you think? Should we start with this? Not in naive patients, in a switch setting. In naive patients, it's more than 5%. Then we suggest, should we react? Should we discuss a switch? And then we decide with the patient together. But we don't wait too long until we offer the switch.
Thank you. More than 3%, I understood. More than 3% in patients that switch, and more than 5% in naive patients.
Yes, because we see in the naive patients coming back to more normal. There is, from our point of view, it's a normal weight gain in a part, but and also it depends on the kilos with which you start. This is only a marker. So we look then if you have this weight gain, and then we discuss with the patient and think in our team, does it make sense to switch or can we continue? It's only an offer. It's not a decision, it's an offer. And then we decide, okay, how we react. But we don't wait until the patients have already 10% weight gain, because it's really hard and difficult for our patients here to lose the weight again. So this is one of the problems.
Okay. Do you think that metabolic syndrome is another situation to change patients, that they develop metabolic syndrome like in advance for example, 8.5% of patients that start a regimen with dolutegravir develop metabolic syndrome. You think is another way to change a regimen, for example, from integrase inhibitor to a PI or a non-nucleoside?
Yeah, for me and from my point of view, the PI makes no advantage in metabolic syndrome so far. The only thing where is a discussion is peripheral insulin resistance. There might be a discussion, but if you have high lipids, the PI is not the solution.
Okay, I think there is a physician who wants to do a question. Esser, please.
Hi.
Hi.
Good evening. Nice to see you.
Good evening. Dr. Esser, congratulations for your great talk. And I have two questions for you. The first is, if you have, what is your opinion about the use of Darunavir, cobicistat with a patient without dialysis or substitution of the renal function? Because here in Mexico we have a lot of patients in that state, and there is no data about the safety and efficacy of Darunavir cobicistat in this kind of patients. And the second, do you want to answer that, or
you mean patients
if you want,
with
give you the second question?
Do you mean when they have a change
with severe renal impairment without?
Okay, yeah, this is a very important question.
With, if you advanced renal,
when it's really advanced, it doesn't matter. But if you have a change in the renal function, the protease inhibitor promotes this. So we would try to switch away from the boosted protease inhibitor, and also from cobicistat if you see a worsening in the kidney function. But if it's, for example, if the patient is already in dialysis, yeah, it's the right word, I hope. Yeah. Then it's no problem anymore. Then the protease inhibitor, for example, has also some advantages. For example, you can make also a drug level and look if the drug level is enough. Then it doesn't matter. But if you see really that the kidney function loss, then I would think about a change of this regimen to a less kidney toxic regimen.
You. And yeah, thank you so much. And the other question that I have to you is, there are many patients that have failed to multiple regimens previously, and they have acquired a lot of mutations that compromise the protease inhibitors. And when you put all the mutations in a Stanford database, maybe Darunavir is in low-level resistance. And here in Mexico, there is an indication to rescue that patient with double dose patients, chronically suppressed with optimized background regimen, with double dose of Darunavir, but develop a lot of comorbidities, polypharmacy, and adverse effects related to double dose of Darunavir. Do you think when you have a chronic suppressed patients with optimized background therapy with double dose of Darunavir, it's possible to, in the future, simplify the regimen with low dose of Darunavir, or it's not possible to do that? It's too risky. I want to know your opinion about that.
This is a very good question because we have the same discussion in our team. And we have decided to try this, but only in patients, not if we start. If somebody has a biological failure, then we start and has a lot of resistance and everything. Then we start with 2 times 600 milligram a day, both boosted. But if they are more than 6 or months under the level of detection, then we switch to once daily regimen. And our experience so far is very, very good. We see nearly no biological failure, except if the person has compliance problems. So the question is very good. I think it's possible to simplify the regimen if you have really 6 months, no viral load anymore.
Thank you. Congratulations.
But I have to add something. We discuss this, of course, with our virologists and look for the mutations. If you have many Darunavir mutations already, especially primary mutation, then you have discussed. But the most don't have so many Darunavir mutations that you need a double dose for the whole life of the patient. So I think it's you act responsible when you decide to reduce, because you have a big advantage, in my opinion. This bad data from the DID trial with the increased cardiovascular risk is caused by the higher dosages, because when you see the hyperlipidemia is lower when you reduce ritonavir and darunavir to a single tablet regimen or once daily dosage of 800 milligrams and COBI. So I think it's a good idea always to prove if you really need this highest dosage and to give the patient the advantage that he has less adverse events. So I think in many patients, a good idea to try to simplify the regimen. And we have good experience with this. Thank you for this question.
Stefan, regarding this question, I don't remember if in Dualis, you had patient with double dose of dolutegravir when you simplified to darunavir ritonavir once daily, or
no, all patients who has already once daily dosage of darunavir. It was not a switch from 2 times to 1 time or a QD regimen of darunavir.
Okay. Well, thank you, Stefan, for your kind presentation, for your time, for the time of the question. That there are always very interesting the discussions. We have 20 minutes discussion about the Darunavir cobicistat, and I think we appreciate your time, and thank you so much for this presentation.
Thank you so much for your invitation, and sorry about the technical problems at the start. You know, the last times I don't have, but today we had some problems here at the University Hospital. I hope they are solved tomorrow. Thank you very much. And it's very interesting always to discuss with you and your colleagues. And it's interesting that we have the same problems in Mexico like in Germany, and we have the same discussions. So it's very good that we share our experiences with each other.
Thank you so much, Stefan, and see you soon.
See you soon. I hope so, Antonio.
Yes, I hope so.
Goodbye.
Bye.